Feel us and see what's going on.
Very good.
Yeah.
I guess we should start.
Yeah.
So, good afternoon, everybody. Welcome to this session. My name is Bernd Sauge from Hamburg in Germany. I have the pleasure to chair this session together with my co-chair, Professor Michael Chu from Sweden. We have a very, very interesting session on cardiogenic shock, spanning from general management to extracorporeal support. We have excellent speakers from all over Europe, and I'm very happy to ask the first speaker to the stage, Professor Roberto Lorusso from the Netherlands.
Thank you very much, Mr. Chairman. Thank you for the kind invitation to the organizing committee.
Could you please bring up the slides for the speaker? I guess they are working on it.
Yeah, okay. Thank you very much. Appreciate it. So these are my disclosure, but the most important disclosure, I think that I am a cardiac surgeon dealing a lot with cardiogenic shock, and I'm inevitably biased because I certainly more prone to consider more aggressive treatment than drugs, but particularly in refractory shock, and after having read all the results of the trials for cardiogenic shock treatment with drugs, unfortunately, I must say. So I just want to start with a 20-year-old study, the GASO in the year 2000, and the results, the outcome were quite disappointing. As you can see, lack of progress in cardiogenic shock. And the editorial in the European Heart Journal made another very, very heavy statement that the more aggressive approach is now warranted. Well, after 21 years, I don't think we had a lot of progress as well. And indeed, if you can see, 12 years later, the global registry acute coronary events, a lot of patients, thousands of patients. But again, if you look at the outcome along the years of the study, you saw no progress whatsoever with 60% in-hospital mortality in patients affected by cardiogenic shock. And again, the authors stated continued effort, more aggressive approach, but I don't think that followed up this statement. And you know very well the SHOCK 2 trial from Olga Tiera and colleagues. And unfortunately, looking at the YABP in this time, and the control group, again, unfortunately, no difference, but with a 40% in hospital mortality. So again, really disappointing. But let's have a look at what the vasopressor. I'm not going into, of course, the details because the speakers following me will go more in depth, but just to show you why I'm going towards some evidence that I'm going to show you. And again, this is a vasopressor. As you can see very well, if you need two vasopressor, you can have a very ominous prognosis in refractory cardiogenic shock. And if you, again, continue regarding the norepinephrine as a first line, in the cardiogenic shock, you can see that you have quite also high adverse effects, but particularly in refractory cardiogenic shock, because at the beginning of cardiogenic shock, drugs can really be also very useful. But in the refractory patient, that is really not the case, unfortunately. And if we see another very recent study comparing mirinon and dobutamine, you can see in this population, in this patient cohort, again, unfortunately, no difference in outcome. But again, you can see also the event rate very high in these patients. So this was another study comparing epinephrine and norepinephrine. As you know, I think all of you are aware about the really higher rate of complications in the epinephrine group. And you can see here that the amount of refractory complication adverse event in the epinephrine group was much, much higher than norepinephrine. So I'm not sure that we have really good information and good news from this setting. But if you look at the meta-analysis here regarding all the vasoconstrictors and inotropics, again, this is not really good news, because if you can see 90 days mortality and after 90 days, there is no impact, no influence of the use of inotropics or vasoconstrictors. So the question comes quite obvious. So from the year 2000, we had a question, actually a plea towards more aggressive, but was it really performed after 20 years? So I think that we should look whether we should be more reactive, more aggressive, and particularly having a more dedicated group of people addressing these patients. So this is a recent study, and I think it's very important because we all know that the use of right heart catheterization now in cardiogenic shock is, I think, really almost a must, although it was neglected in the past. So this is the very first, I think, important news that this is back. So Schwann-Ganz catheter and all the things is now back in town. And not only that, I think that we will see that the new guidelines of the European Society of Cardiology just released a couple of days ago. I think there is a push towards more the use of mechanical circulatory support in these kind of patients. And this is a very interesting study showing the trends and incidence of the use of mechanical circulatory support in cardiogenic shock. And I think this was really interesting because you can see, again, no change in mortality along the years, but look at the amount of the rate of the use of mechanical circulatory support. Very, very low in these patients. So mortality almost unchanged, but also the mechanical circulatory support. So again, bad news. But looking at the etiology, I think this is very interesting. The etiology, you can see that the red is the myocardial infarction. And you can see that the etiology is changing, so less and less myocardial infarction, acute myocardial infarction, and more other etiologies like acute heart failure in chronic cardiomyopathy. And also the kind of mechanical circulatory support for the balloon pump, there will be a speaker afterwards, but you can see that the balloon pump really sharply and remarkably decreased with the increase of other mechanical support. Another very important study was this one, about the trends in mechanical circulatory support, again, in refractory cardiogenic shock in the United States. And you can see, again, I mean, this was a very huge study, more than 140,000 patients. And you can see clearly, again, that the amount of non-AMI are increasing. So it's a confirmation that non-acute myocardial infarction, cardiogenic shock related is really increasing. And also the type of mortality, again, you can see after a very short period of improvement, again, we are here in terms of in-hospital mortality, almost 55%. So again, disappointing, as you can see. So I think that another look at what kind of mechanical circulatory support. As I said before, intra-aortic balloon pump declined constantly and I think inevitably because of the SHOCK 2 trial. But if you look at the Impella and Tandem, so percutaneous, you can see a sharp and remarkable increase. But look at the amount of use, 3.5%. And what about ECMO? Yes, again, increase, but look at the actual rate of implantation, 6%. So really, really low. And you can see here the total amount of the figure of this study, that in-hospital mortality was significantly lower in patients receiving mechanical circulatory support, and this is important, whatever was the age. And this is a very important information. So just about the age, this is, I think, another important finding of this study. What about the profile of the patient affected by cardiogenic shock? They look, of course, the results are quite old, but I think very impressive because the young patient, the rate of young patient decreased, you can see, of every age below 64. But look at the elderly patient, they both increase. So we are looking and we are witnessing an increase of age of patient in cardiogenic shock and a decreased rate of the young patient. And I think that was important because we made this study using the ELSO registry. We look at elderly patients, more than 700 patients receiving ECMO for refractory cardiogenic shock. And you can see, again, this confirmed the previous study findings that almost 15% of the total patient population of the registry, more than 150,000 patients worldwide, is consisted by elderly patients above 70 years of age. So this is another very important issue. But what about the outcome? Well, in this very complex and very high-risk patient population, the in-hospital mortality was around 30%. Is it very low? Well, I don't think so, because these patients could have been all dead at the end of the in-hospital stay. So looking at 30%, is it too low to contraindicate? I don't think so. So we should be careful about selecting, but I think we should consider. So the management, as you see, is changing. It's changing because of the type of patient, the patient profile, the age of the patient, also the type of etiology. So this was an update in 2019 from Olga Thiel and colleagues. As you know, the SKY classification, so from A at risk to E in extremis or in emergency, so with a patient in profound cardiogenic shock. But what do they say? So they look at all the studies, and again, mostly with vasopressor, but not only, also shock 2 with the intra-aortic balloon pump, and also with the very first percutaneous mechanistic support. Again, unfortunately, no major differences. So also the kind of studies I think we should receive should be much more, I think better done. And I think that so far we had very low patient cohort, and I think also the study design, I'm a little bit doubtful about that. So now, the new European Society of Cardiology, as I said, just released 2 days ago. So what do they say? I think this is very important. And you can see here, very important, inotropic and vasopressor, 2B, 3 or 2B, again, for vasopressor and inotropic. So again, we have here quite a sort of word of caution about that. But if you look at the mechanical circulatory support, also very interesting, because this is 2A and 2B. So for the first time, mechanical circulatory support looks much more recommended than the drugs. But what I still, this is a very personal opinion, what I don't understand at all is the EIBP should be considered in all the other cases of bridge to recovery, bridge to decision, bridge to bridge, but then the EIBP should not be recommended in post-MI cardiogenic shock. It's like, giving a contradictory statement. So I've never been so I would say, fan of this statement that the IBP is a 2A for mechanical complication of post-MI, but if it's for a general cardiogenic shock, then it's not recommended. Sorry, I don't understand. So what about the other things? Again, the recommendation, I think that it's very important. The short term may be considered in refractory cardiogenic shock depending on patient age. Again, I'm not sure about that because we demonstrated that even elderly patients, of course, without severe comorbidity, with a short duration of support, they can be really relieved and they can be saved by mechanical circulatory support. So, furthermore, I think that these are just, of course, suggest to go through these guidelines because they show you about all the steps and all of course, the recommendation, but particularly for mechanical circulatory support, now they are completely in the line of the European Society of Cardiology guidelines as compared to the past. So, but what is, I think, important is now mechanical circulatory support is absolutely recommended as class 2A in refractory cardiogenic shock, whereas drug is 2B or even 3. So now this is in place. But not only that, I think that we know that left ventricular unloading is very important during a reperfusion injury and can mitigate the extent of myocardial infarction. This was an animal study. You can see putting 30 minutes on support before reperfusion, before opening the coronary artery during an infarction. This gave a very, very significant reduction of the infarct area. So putting the heart at rest, even during an infarction, is much better than opening immediately the artery. So this is quite astonishing, but this was the result with the editorial that acute mechanical unloading in ischemic reperfusion injury be prepared. And to go on, so this is changing the management, the general management of acute myocardial infarction and refractory shock. You can see here we have prompt recognition, then we have activation of the shock team. This is another new concept that is going to be very, very in place. Then the assessment of the patient, and then the 3 types of management. So continue optimal medical therapy or escalation to mechanical circulatory support, or even decide that this is the case of a palliative care. So this was put in place in the Detroit area. You can see here that the results before structure strategy was such with a 51% survival, but then after they put in place a structure strategy, you can see much better results. So this is very important. And again, these are the new concepts. Should we dedicate even the place, not only the team? I think that there are a few papers now stating the cardiogenic shock center in the general management is certainly a good idea and much better. And I think, again, you can see level 1, 2, 3 to treat the patient, and also how you prepare the patient for such a situation, because maybe you can even go into mechanical circulatory support state and you need to be prepared with the patient. So this is very important. And finally, just to show you that centralize the patient is better than going to the closest hospital, this was a study in Denmark, and they showed that if you go to the closest hospital or you go to a dedicated center in cardiac arrest, so not in cardiogenic shock, look at the survival. It's much better if you go to a dedicated center. So that's very important. So timing is an emerging concept, very important. And also, I think that this one, I think, is a good statement, treating cardiogenic shock and cardiac arrest in the right place, the right time, and with the right instrument. So I think in conclusion, I showed you that the incidence of cardiogenic shock is steadily increasing, but unfortunately not the survival. The mortality is really still disappointing, and the last 2 decades, not the last years. So the drugs, we'll listen to the following speakers, but I doubt this in refractory cardiogenic shock are really a solution. I think we have to have a paradigm shift from really non-aggressive, but will be reactive and aggressive, and particularly with mechanical support, which is increasingly considered, but still very low. The rate is very low. And I think there are many now devices. We will listen from the next speakers. And I think that at the end, we need, of course, good trials, good evidences, and these are ongoing. Thank you very much.
Thank you very much, Professor Lorusso, for that excellent walk through current evidence. You really opened my eyes, and I'd like to ask the audience to come up for questions, because I certainly have lots, and we probably don't have time for all of them. Okay, while we're waiting, I was, like you, disappointed to hear that the mortality for cardiogenic shock has not changed since the Gusto trial. I thought that it had. So thank you for clarifying that, and thank you also for clarifying for us intensivists that really believe in vasopressors and inotropes that we might not be doing the right thing. And it certainly is a paradigm shift, at least for me, that doesn't normally work with mechanical support devices, that this might be the first line agent that we should be choosing. Now, you mentioned that age is no longer a contraindication or a relative contraindication. So if I put you against a wall
Well, this is a very good question, but I think again the paradigm shift should involve all the way you look at the patient. I mean, do you deny dialysis in a 70-year-old patient? I don't think so, unless you think that it's really, really futile. And even, I think, a mechanical circuit support, if you reduce very much the complication, because I don't deny that you have complication, but now complications are going down and down with more expertise. So at the time, the complication will be very low. Would you deny a support of maybe 48 hours to see if this can change in a patient, again, with no major comorbidities, because that is certainly a problem. So I think in the future, patient selection for elderly will be very critical, as it is now, but we will have more evidences, and I would not consider age of 70, 72, 75. I mean, my oldest patient had 80, and he survived because, of course, it may be a bias of selection. Sure, I don't deny that, but what I want to say is that you can still save patients.
Excellent, and I'll be waiting for those selection studies.
Yeah, thank you.
No questions? Thank you very much, Professor Lourdeau, for that excellent lecture. So I'd like to welcome Professor John Parissis from the, I can't actually say the university, but from Athens in Greece anyway. Very
Athens,
welcome.
University of Athens, Attikon General Hospital. Okay, thanks. I will speak about the use of inotropes and vasopressors in the management of cardiogenic shock. I think Roberto covered very well some points in this topic. My disclosures. I agree with Roberto that the only approach that improved the mortality the last year is the creation of cardiogenic shock centers at the team-based approach, including also reasonable use of mechanical supported inotropes, because you can see here that the mortality of cardiogenic shock in European Society Cardiology Registry in real-world data is very high, 39% in hospital mortality at 54 1 year after the discharge of the patients. And I think that the cardiogenic shock is an entity different, if you see here, from the classical wet and cold patient of advanced heart failure or the hypotensive patients. The ischemia, the presence of ischemia, the alterations of microcirculation kills really this patient. And if you see the trials, the mean ejection fraction in cardiogenic shock is 35, about 35. And the mortality is very high, while in advanced heart failure, the mean ejection fraction is lower than 30 in clinical trials, and the mortality is lower. Thus, I think it's very crucial also the clinical classification of cardiogenic shock. Serum lactate is a very important biochemical factor that can divide the patients according to these levels from the classical shock to refractory shock. Over 5 is very bad prognostic factors. Potentially is very good factor to guide the treatment with inotropes. And also there is a need for step-up therapeutic algorithm according to the stages of cardiogenic shock and the reasonable use of inotropes and mechanical support. For example, in deteriorating shock, I think that there is a need for early mechanical support despite the use of multiple vasopressors of inotropes. It's a characteristic of this stage, the use of multiple over 2 or 3 vasopressors and inotropes. The classical indication from European Society guidelines is the wet and cold patient if the systolic blood pressure is lower than 90. There are signs and symptoms of hypoperfusion. The first choice inotropic agents. If there is pre-shock conditions with higher systolic blood pressure than 90, there is an specific consideration for the use of vasodilators in the first step. And then if there is refractory shock or refractory hypoperfusion, the next step is the inotropes. And after that, the third step is the use of mechanical support, at ultrafiltration in some cases. There are a lot of drugs, the classical beta agonists, including dobutamine, dopamine, the vasopressors norepinephrine, epinephrine, the phosphodiesterase inhibitors, and also the new one, the levosimendan, the calcium sensitizer. Potentially, The phosphodiesterase inhibitors levosimendan acts as anodilators, having also, except the inotropic action, a potent vasodilatory action. And this is very important for the clinical practice to combine these factors sometimes with vasopressors like norepinephrine, especially if the systolic blood pressure is low at borderline lower than 90. Looking at the registries, here is the registry of alarm, including more than 4,000 people. You can see here that across the different regions, the dobutamine remains the most popular drug for the treatment of cardiogenic shock. Over 50% used used dobutamine for the treatment. The second one factor was norepinephrine in 1/3 of patients. There are also some combinations in about 20% in alarm registry. The other thing, more recent data from the European Society Registry, you can see here that inotropes used for the treatment of cardiogenic shock in 80%, vasodilators in 14%, diuretics also in a very high level. But it's very important to see that mechanical intervention are still low in clinical practice. You can see here coronary angiography, PCI, also the use of intra-aortic balloon pump. The percentage of patients treated with these interventions were very low in real clinical practice. That it means we need more aggressive treatment in these patients in order to improve mortality. Data from Cardiogenic Shock trial, you can see here recent publication in critical care. The most popular in Cardiogenic Shock trial, the norepinephrine, 75% received. From classical inotropes, again, dobutamine. There are a specific combination, the most frequent dobutamine and vasopressor. But also there are some, you can see here some wrongs in clinical practice. For example, you can see here for levosimendan, there is duration of infusion over 40 hours. But the classical indication is 24 hours for the use of this drug. And also some other use of, for example, epinephrine, which is harmful in the last trials, in relative high percent. That means there is not only with the effects of the drugs, but also with the wrong use of these drugs in real clinical practice. This is also a good algorithm, including the use of inotropes according to the pump dysfunction, the two-shock hypoperfusion, the hypotension. For example, left ventricle is better dobutamine. For coexistence of right ventricle failure, is better to use Milinon or levosimendan. And finally, vasopressin is the last solution if the mean arterial pressure is still low under the treatment with other two factors. There are many disadvantages in clinical practice: increase of afterload, increase of arrhythmogenesis, of chronotropy in patients receiving inotropes. And this is related with higher mortality in registries like alarm than other drugs like diuretics and vasodilators. But I think, again, the timing is very important. The early use in this very important trial from Frank Peacock, from the emergency department at US intensive care units, you can see here the use in a time lower than 10 hours is related with lower mortality than the late use after 10 hours in these patients, because the late use is associated with more hypoperfusion, more higher lactate levels, and finally worse prognosis. That is very important, the early use. The new guidelines also consider this treatment as 2B, as Roberto reported previously, is weak evidence. Is still the same evidence. This is the guidelines of 2016, 2B again. In these guidelines, there is also a specific indication for levosimendan as an alternative treatment to dobutamine if the patient received beta blocker before the appearance of symptoms of hypoperfusion. And as a vasopressor, there is specific recommendation for norepinephrine mainly. There is the same indication in the new guidelines But the more general recommendations, the recommendation for levosimendan deleted in these guidelines as an alternative treatment in patients receiving beta blockers. Few data, randomized data in clinical practice. This is a classical trial, subgroup of patients of cardiogenic shock, comparison of norepinephrine with dopamine. In cardiogenic shock, there is superiority of norepinephrine in improving mortality in these patients than dopamine. Harmful effects of epinephrine. 2 trials, one randomized, one propensity match scores analysis, and one meta-analysis. Epinephrine use was associated with more refractory shock, higher lactate levels in these patients, and higher mortality. The new trial in New England Journal of Medicine, published before some days, comparison between millinol dobutamine. The primary endpoint was similar in 2 groups, no difference. No difference also in biochemical findings like lactate, urine output, and other secondary endpoints. But it's very interesting to see here, in this sub-analysis of DOREMI trial, this trial, that patients pretreated with beta blocker in both groups had fewer effects of resuscitated events, also fewer deaths in hospital. It means that beta blocker, pretreatment with beta blocker, protects these patients from some endpoints in patients with cardiogenic shock receiving inotropes. Potential beta blockers reducing inflammation, reducing sympathetic activation. It is very important to know in clinical practice. Between levosimendan and dobutamine in cardiogenic shocks, there is only this propensity match score analysis from CardioShock trial. No difference, but in both groups there is combination with norepinephrine. It's better sometimes. This is data from Great Network of Alex Mebaza. It's better to combine inodilator with vasopressor, not only to use vasopressor, but also to combine a vasodilator like dobutamine or levosimendan with vasopressor in order to have better hemodynamic effect in this patient. And for levosimendan, this meta-analysis demonstrated also a mild positive effect on mortality cardiogenic shock patients, but few trials, small number of patients. There is no prospective trial with levosimendan on cardiogenic shock. But I think it's very effective drug in patients with acute right heart failure, with elevated pulmonary pressures. This drug reduces effectively the pulmonary artery pressure, improves right ventricular function, and also improves TAPS in these patients. And it's also a solution, levosimendan, small dose of levosimendan and norepinephrine in cardiogenic shock from Takotsubo cardiomyopathy. Because in Takotsubo there is contraindication for the use of catecholamines. But the use of a lot of inotropes, I think it's a very bad prognostic factor. In these patients, we need early the use of mechanical support. And I will close my presentations with 2 last slides. This is a step-up therapeutic algorithm using inotropes according to the stages of cardiogenic shock. For example, in ominous cardiogenic shock, there is only volume permission. In compensated cardiogenic shock, we can start with a classical inotrope dobutamine, and also an alternative levosimendan if there is right ventricular failure. In overt cardiogenic shock, to combine levosimendan or dobutamine or levosimendan with vasopressor. In refractory shock, to combine, except the 2 classical factors, norepinephrine, dobutamine, to combine with vasopressin, and finally to use only epinephrine in resuscitated cases. In my take-home message, I think the treatment of cardiogenic shock is very crucial to identify the underlying etiology, to treat the etiology of cardiogenic shock, first of all. Second, to start early vasoactive therapy. Norepinephrine is the preferable vasopressor. Epinephrine is shown to be harmful. Anodilators seems to be better than inopressors, but the combination of inodilator and vasopressor seems to be also more beneficial. Dobutamine is still recommended as the first-line treatment, but the law of evidence regarding all inotropes is low, the level of evidence. Levosimendan can be used most often in patients with acute right ventricular failure, Takotsubo, on beta-blocker therapy, in the majority of cases in combination with norepinephrine. The use of mechanical circulatory support need to be considered if there is ongoing organ injury despite the vasoactive therapy. Thank you for your attention.
Thank you very much for this nice summary of vasopressors and inotropes in cardiogenic shock. I'm sure that there are questions from the audience. Here's one.
Yes, one. Would you recommend first vasopressor or inotrope therapy, or both simultaneously?
It depends on the... In resuscitated to patients, I will start with vasopressor. The potential to use epinephrine in these patients. This is a classical in algorithm of resuscitation. But for the shock, the classical shock, I will use the inotropes according to the stage. What is the point to classify these patients? The serum lactate, potentially, the hemodynamics, sometimes. Some patients need also hemodynamic monitoring in order to see the transition from one stage to the other stage. And I will start if there is pump dysfunction with a classical inotrope and to add a classical vasopressor, like norepinephrine.
Any other questions? If not, I have a very short one. You showed the study from 10 years ago investigating which vasoactive agents were used back then, and I noticed that dopamine was used in quite a substantial fraction of the patients. Any place for dopamine today?
Any place for?
Dopamine.
Dopamine. Yeah, but there are two negative trials in acute heart failure. The ROSE trial and the DAD2 heart failure trial was associated. Also, there is some analysis in a recent European Society registry that dopamine was associated with the highest mortality than other inotropes. And the main barrier is the tachycardia. It increases excessively the heart rate in these patients. Thank you.
Another question? We still have time because you finished a little bit earlier. There is one.
What about the use of vasoconstrictors? Use the microphone, please.
It's difficult for him to
What
get
about
to.
the use of vasoconstrictors?
Vasoconstrictors with beta blockers.
With beta blockers.
Together.
Yes.
Yeah, it's a very good question. I think there are only trials with vasoconstrictors and IV blockers with landiolol. Only with landiolol because it's short-acting factor, very, very selective, without negative inotropic action. And there are some data, especially from Japan, that is extensive use in Japan of landiolol, that can combine this factor in order to reduce the heart rate without negative inotropic action, and to have also the inotropic action without excessive sympathetic activation of dobutamine. That I suggest only carefully this IV beta blocker.
Thank you very much. And with this, we will proceed to the next speaker. And we ask Professor Antoine Herpin to the stage, who will answer us the question whether we should use milrinone or levosimendan.
Thank you. Thank you for the kind invitation. It's indeed so good to be here, face to face, for me without mask. So let's continue indeed with the same question of the ideal inotrope that we should use in the cardiogenic shock resuscitation. And my case today will be to compare milrinone with levosimendan. These are my disclosure, the very first one being related to the field of today. So I propose you to address this really important clinical question by looking a little bit more in details to 4 important features of these drugs, which are the mechanism with which they are going to increase inotropy, how they are able to vasodilate also the peripheral arteries and then to become the so-called inodilator. For specifically the levosimendan, how it might protect the heart if you give it before ischemia reperfusion injury. This is the so-called cardioprotection feature. And then a few words about pharmacokinetic, if I will still have some time in my presentation. So let's jump immediately on the field and discuss inotropy. As you might know, I think all the adrenergic agent will stimulate the beta adrenergic receptor on the myocyte's surface, membrane surface. And the role of milrinone as a type 3 phosphodiesterase inhibitor is to reduce the speed at which the increase in the AMP cyclic will be again normalized and come back to normal intracellular concentration. And this is really important to come back to this really pharmacological basic principle, because this rise in cyclic AMP that is induced by, again, any kind of adrenergic stimulation, whether it is an exogenous stimulation coming from the drugs that we are giving, or if it's endogenous coming from autonomic nervous system, this rise in cyclic AMP will actually increase the oxygen consumption of each myocyte, because it will dramatically increase the amount of ATP consumption related to all the calcium handling process. So the way the calcium is moved from one compartment to the other one, or from the external part of the cell to the intracellular space. And all this calcium handling has a cost in terms of energy. And this is why all the adrenergic agent, and especially also the phosphodiesterase inhibitor, are related with an increase in myocardial oxygen consumption, the so-called MVO2. And this is important because then when you're going to stimulate your heart with this adrenergic inotropic support, you are in one hand going to increase this MVO2 because you increase the stroke work of the heart. You increase the heart rate, so the total power output, the amount of energy spent by minute. And as I just told you, you're also going to increase this calcium handling process-related oxygen consumption. On the other hand, due also to this tachycardiac effect, you are going to reduce, at least for the left coronary artery and the left ventricle, the amount of time that is dedicated during the diastolic time to perfuse the myocardium. And so you end up with an unbalance between an increased MVO2 and a decreased MDO2 for the heart. And this is one of the key principles of the adrenergic toxicity, which is again related to any kind of adrenergic agent, milrinone being included in this reasoning. And this is probably even more true for the subendocardial layers of the myocardium that are so-called silently suffering from this process, because this is not a kind of transmural injury that you can detect easily with echo or EKG, but something more specific to the last layers of the myocardium, which is related to a less efficient coronary blood flow autoregulation. And one could say that, okay, this is maybe important, all the story of oxygen consumption when the patient is suffering, for instance, for an acute myocardial infarction. But as soon as the patient is revascularized, reperfused, maybe this is less important because now oxygen is flowing again in the myocardium. But this is not true. This has been, for instance, shown here in these preclinical studies by our colleague in Leuven, which have demonstrated that the final size of the myocardial infarction is strongly related either on the left side of the panel with the MVO2 during the ischemia, but also, as it is shown with the correlation on the right part of the slide, with the MVO2 during the perfusion period that followed the revascularization. So really important to keep that in mind. If now we switch to levosimendan, as I guess now after more than 20 years of clinical use of levosimendan, you might know levosimendan is not related to this kind of increase in myocardial oxygen consumption, because the way it increased contractility, and in this John Parisis is really happy because this is one of his reference. The way it increased contractility is actually related to an optimization for all the key players that are already available within the cell, if you allow me to summarize it a little bit simplistically. So the story is that you're really going to stabilize the conformation with calcium and troponin, and the way it will then perform, I will say, a prolonged binding between actin and myosin. And we have several proof of this concept that it's not related to any increase in calcium flow inside the cell and than oxygen consumption. Some proof are coming from the in vitro studies. Some are coming also from the preclinical model, here with the swine model of acute myocardial infarction. I'm sorry I don't have the time now to go into the details of these studies. And we also have some clinical, less invasive measurement, as is shown here, for instance, with nuclear medicine indices that have been used on patients suffering from severe dilated cardiomyopathy. And in all these studies, the message is roughly on average the same. There is no significant increase in MVO2 with levosimendan, whereas it's clearly always the opposite with the adrenergic inotropic drug. Is it exactly so simple and so binary with a black and white relationship? No, clearly, as is often the case in clinical practice, things are a little bit more complex. And actually, one could argue, and it's true, that with high dosage, when you are especially giving a bolus of levosimendan, you could induce a kind of type 3 phosphodiesterase-like phosphodiesterase inhibitor-like pharmacodynamic action. And this is something that we see mainly again by using bolus with the mother drug, which is less something that we observe when we have a long-lasting observation with the patient that now, as I will show you at the end of the talk, are more taking the benefit of the first metabolite of the drug and not the mother drug per se. Nevertheless, keep that in mind because this is some nuance that you have to understand. Nevertheless, if we compare now, and again, we have to switch back to the preclinical model where invasive observations are allowed. If we compare milrinone in front of levosimendan in terms of oxygen consumption cost, you can see in this quite busy slide that actually to obtain the same increase in contractility, which is expressed here by the dPdt of the left ventricular pressure, you can see that the cost in oxygen consumption is way more higher in the animals that were infused by milrinone. What are the clinical consequences of all this? As you know, I can imagine a little bit more convinced. There is a strong feeling, it's more a feeling, a strong belief that this adrenergic stimulation is really harmful for this heart that are especially already quite exhausted in the setting of the cardiogenic shock. And this is something that we can already observation that we could draw from the clinical studies, not in the field yet of cardiogenic shock, but from the acute heart failure. This is already an old study, 20 years ago, the Optime CHF trial. The large study, 1,000 patients suffering from heart failure, decompensated heart failure with reduced ejection fraction. And half of this cohort, and it's important, was known to be suffering from an ischemic cardiomyopathy. Keep that in mind. And so the study per se didn't show any difference when these patients were randomized for milrinone or placebo in terms of survival. Again, I have to insist that these are patients suffering from heart failure and not cardiogenic shock. That was at that time an exclusion criteria. But when we go a little bit more into detail and we look at the subgroup analysis, so admittedly one level down in terms of evidence-based medicine, you can see that in these 500 patients new for ischemic cardiomyopathy, the ones that were randomized for milrinone actually had a reduction in survival, showing again this kind of really bad relationship between ischemia, oxygen delivery to the heart, and outcome. And as the previous speaker have already shown you, we have since this summer at least one good monocentric randomized controlled trial that compared the milrinone prescription to dobutamine in the specific setting of cardiogenic shock. This is a Canadian monocentric trial. This is a mixed cases of cardiogenic shock, so related to acute myocardial infarction, but also other kinds of etiology, which is something really important that we do not often see in the cardiogenic shock literature these years. And these patients, when they were admitted in the ICU without any kind of inotropic support, they could have been already under vasopressor therapy, but they could not have any kind of inotropic support already on board. And so when they were admitted in the ICU, they were randomized, as you can see, for milrinone or dobutamine in a double-blind fashion, really good design. Primary endpoint was, as it's often the case in cardiology literature, quite broad, with a large of items that compose this primary endpoint. But as we have again already seen with the previous speaker, this study, although it's really showing a nice design, is actually completely neutral, whether you're looking at the primary endpoint or each of the composite items of the primary endpoint. And this is true as well if you look to the specific case of the patient under beta blockers. And you can continue to dig into the detail, trying to find something with the young people, the old people, according to the previous heart disease and so on. This is a complete neutral trial. Regarding levosimendan, you know that in the field of heart failure, there is also a negative trial. We don't have any good randomized control trial in cardiogenic shock for levosimendan. We only have in heart failure, completely neutral as well. But then in this case, the situation was slightly different for the case of beta blockers, because there the patient had recently received some kind of beta blocker agent. They have shown in subgroup analysis again an improvement in survival. And this is why back at that time in 2016, the previous edition of the heart failure guidelines had already showed a kind of recommendation, grade 2B recommendation in the sense of favoring levosimendan in this specific context of recent beta blocker interplay. If we now switch to the field of the critical care, the cardiogenic shock, we only have this kind of really broad and heterogeneous meta-analysis with patients here that at least have inotropic support needs and low cardiac output syndrome. And you can see that we have really a heterogeneous merge of really different kind of studies. At the end of the day, if there is any signal to draw from this meta-analysis, it is at least in the favor of positive information regarding levosimendan, but from the evidence-based medicine standpoint, this is clearly low evidence. There are only pieces of information, but again, quite scarce, is coming from this monocentric randomized controlled trial that performed a head-to-head comparison, a monocentric trial, a really short inclusion and small cohort, that back at that time, in 2008, in this German center, compared levosimendan with a type 3 phosphodiesterase inhibitor that was not milrinone, but enoximod, but we can take this this comparison as reasonable. And this patient that are suffering from refractory cardiogenic shock after acute myocardial infarction were randomized. One good piece of information, at least, that we can draw from this study is that the amount of vasopressor therapy that was needed to support the vasodilatory effect of enoximod was way more higher than the one related to levosimendan. And the resuscitation being completely similar in the two arms of this study, we have seen at that time that the survival was increased in the patient receiving levosimendan. Again, really small cohort, so take this information with a pinch of salt. And this is why, at the end of the day, 3 days ago, we have observed the release of the new 2021 guidelines regarding acute heart failure and also cardiogenic shock resuscitation. And as you might already know, there is only a weak class 2B recommendation to give any kind of inotrope or vasopressor support in this patient without any further recommendation, at least strong recommendation for any kind of agent. If we now go back to the point of the vasodilation, which makes of this agent inodilator, they are both acting on the vascular smooth muscle everywhere on the vein and the arterial side. This is quite similar, although the biocellular mechanism is slightly different because levosimendan is acting on potassium channel, whereas the milrinone is acting again on cyclic AMP concentration. But nevertheless, the final clinical observation that we can make with this inodilator is that they are able to reduce afterload, to increase contractility, and then to optimize the ventricular arterial coupling, which will promote a larger stroke volume and a better usage of the energy of the heart with a better mechanical efficiency. This is quite similar for the two drugs. But the way these drugs are different in terms of vasodilation actually is not lying in the heart, but on the kidney. Because there, on the kidney vasculature, they really act completely differently. Levosimendan is able to dilate the afferent arterioles with quite a specific action at this stage of the arteriole, meaning that it's not dilating the efferent arteriole, which is the case for all kinds of adrenergic drugs that are somehow vasodilators. It is really important because, as this Scandinavian team has shown in the setting of acute failure or after cardiac surgery, when you compare levosimendan versus dobutamine with an invasive instrumentation measuring the renal blood flow and the GFR, only levosimendan in comparison with dobutamine was able to really increase the GFR, which is what you would like to obtain at the end of the day to optimize your patient renal function. Although both drugs, levosimendan and dobutamine, were able to promote the same increase in cardiac index and the same increase in renal blood flow. And the same team with the same setup has provided a similar study now comparing milrinone versus placebo. And you can see here that the story is different because you have indeed an increase in renal blood flow and cardiac index, of course, but no difference in terms of GFR increase, which is, again, what really matters at the end of the day if you want to optimize the renal function. Yeah, sorry. Okay. So, and this is perceived in meta-analysis as well, because when you compute all randomized controlled trial of levosimendan prescription after cardiac surgery, you can see that on top of reduction of mortality, when you only look at the more severe patient regarding the preoperative left ventricular ejection fraction, you can also see, as it highlighted here in green, that all the items related to the renal outcome are majoritarily improved with levosimendan. And you can either have a broader meta-analysis, as it's shown here, showing again and again that if you compare the patient in cardiac surgery, there is a clear signal for an improvement in renal function and a reduction of the renal replacement needs when they have received the levosimendan. From the cardioprotection standpoint, quickly, only related to levosimendan, this is also related to the potassic channel action, but now not anymore in the smooth vascular muscle cells, but in the mitochondria. And to make a long story short, we only have preclinical data, but showing all the same message, is that if you are able to perfuse levosimendan before, and this is really important, before the ischemia, you will obtain a dramatic reduction of the myocardial infarction size. You will reduce the size by almost 50%, as it is shown here in this first experiment. That has been confirmed later on. And you will even have a kind of dose-effect relationship. So the more levosimendan you give, again, before the ischemia perfusion injuries, the lower will be the size of the acute myocardial infarction. And it's really important from the clinical practice, if you are able to give levosimendan before, and this is again only happening in the field of cardiac surgery, where at least for once you can be present before the injury, which is of course something different than from the cardiac shock resuscitation in the shock lab. You know that a lot of randomized controlled trials have provided neutral results these last 5 to 10 years, but I just would like to focus on this one, the ELVO-CTS trial, that has shown in a pre-specified subgroup analysis of more than 2/3 of their cohort, that if you only focus on the CABG patient of this randomized controlled trial, there in this specific scenario, you can obtain a reduction of the mortality at 30 and 90 days. Something, again, proven in different kinds of meta-analysis with more heterogeneous studies that were used, admittedly, but always going in the same direction that is not followed when you perform the same exercise with milrinone, that is unable in all these meta-analyses to show any kind of improvement, even if you focus, again, on CABG patient only. And it's even worse because you find back the same adverse effect in terms of tachycardia and myocardial ischemia that were already well known from the heart failure literature. I will skip the pharmacokinetic because this is something that you might already know. It's quite easy for milrinone, nothing special to say. Levosimendan has a long-lasting action. And the clinical consequence, there is at least 2 that you should know for levosimendan. The first one is that although the decongestion related to the vasodilation is quite rapid, in 1 or 2 hours, even not a few minutes for the first actions, the one related to the increase of cardiac output, as you can see it here, will take at least several hours, if not half a day, to really obtain the maximal peak in the cardiac output increase. Something you have to keep in mind, and especially if your patient is really on the slope of a crash and burn situation, so to speak. And the other really relevant clinical point related to the pharmacokinetic of levosimendan is the point that the metabolic, the active metabolite, which is the component on which we rely for this long-lasting action for at least a week, is actually completely eliminated by any kind of renal replacement therapy. And so you will lose immediately all these pharmacodynamic properties. Well, having said this, I will jump to the conclusion. So milrinone definitely increase the oxygen consumption. This is related to a lot of side effects and the so-called adrenergic toxicity, really important, especially in the context of ischemic cardiomyopathy and probably also CABG patient. For the vasodilation standpoint, keep in mind that probably the adverse effects related to the hypertension related to the milrinone induction are more severe than the one that we'll observe with levosimendan. from the pharmacokinetic, there is nothing really special to say. The short action could be useful to test if your patients suffer, yes or no, for the beta receptor downregulation, something that you can see with beta blockers, of course, but also in sepsis, in long-lasting chronic heart failure, and especially also in Takotsubo patient. For the levosimendan, the inotropic action is much more safe, and this is clearly at least a message that we can summarize from all the study that is a safe agent, although it's clear that we have difficulty to show a positive signal with positive randomized control trial, but you know that it's something quite difficult in the field of the critical care. I will just insist once more to the specific features of the vasodilation of the afferent artery only, which make really an attractive and appealing agent to treat cardiorenal syndrome, and especially in the context, again, of the cardiac surgery. Cardiac surgery, that it's also a good candidate for the ischemic reperfusion injury reduction, but if you are able to give the vast amount of the levosimendan before the skin incision and the adduction. And last but not least, these are these pharmacokinetic, I would say, pitfalls that we have to keep in mind when playing with it. I thank you for your attention.
Thank you very much, Antoine. As always, I enjoy your pharmacophysiological approach to drugs. I'm really sorry. We have a lot of questions for you, but perhaps we can take it at the end of the session.
Perfect.
Yeah. Professor Antoine Villard-Baron does not need any introduction. If I introduce him, I'll take up all the 15 minutes that he has. Welcome, Antoine, and thank you for telling us about right ventricular function.
Thank you, Michel. Hello, Bern. Good afternoon, everyone. Once again, very kind to be in Brussels for this Congress. So I do not have any conflict of interest for this lecture. So usually, and I am the RV guy, so anyway, I like that. It's always a good thing to speak about RV function, especially in the critical care settings. So we do not have finally so many epidemiological data regarding RV failure-related cardiogenic shock, because as you saw in the previous lectures, usually we speak about cardiogenic shock in general and to adapt the treatment, while we know that there is a very specific point when the cardiogenic shock is related to RV function. To RV failure, sorry. Just to show you some epidemiological data regarding cardiogenic shock in general, it regards 2 to 5% of the acute heart failure admission, whatever the unit. It regards 14 to 16% of the ICU admissions. The in-hospital mortality, as very well discussed, is still very high, between 30 and 60% of cases. And as also previously said, the acute coronary syndrome is still the first cause of the cardiogenic shock, but in decline, from 65 to 45% of causes in 10 years. And so if you look at the pattern of the cardiogenic shock, on the right, the LV point, on the left, the RV point. You can see that by definition, they share whatever the part of the heart. They share the same findings related to shock, which are cool peripheries, cyanosis, orthopnea, delayed capillary refill. But if you look at now, if the cardiogenic shock is related to RV failure, the picture is completely different, as you have many signs of congestion, as you know, and especially hepatomegaly, increased jugular venous distension, and so on. I want to show you these guidelines published a couple of years ago about the CVP, because it will allow me to give you some arguments that we really need CVP at the opposite of the recommendation of these guidelines, which is that central venous pressure should not be measured because of the constraint of measurements. That's very true, and its limits as a marker of preload and of preload dependency, which is very true also. But in the specific situation of cardiogenic shock related to RV failure, CVP is a great help. Why? Because if you look at the definition of RV failure in the critical care settings, sure, you have some sign of shock. Once again, reduced capillary refill, hypotension, tachycardia, encephalopathy, and so on, low pulse pressure. But you have also a sign of congestion and especially increased CVP. And look at here, the CVP first is very elevated, which is a very bad signal, and probably that there is something wrong on the right part. But more in this patient, you see that the CVP, or the right atrial pressure, was higher than the pulmonary capillary wedge pressure, which is very unusual and a very extreme situation. And this patient was really in a very bad shape with a very bad RV function. This is something, and we are a little bit far from the cardiogenic shock as we usually understand cardiogenic shock, because this is more septic cardiomyopathy related, inducing RV failure. But just to show you, for instance, that if you combine the echo, just to look at the RV size, with the CVP, to have an idea of the congestion, you may maybe diagnose some patients with dilatation plus elevated CVP, very suggestive that there is RV failure. And you can see here in the large cohort of septic shock, it was around 40% of cases. That's interesting also because in the cardiogenic shock, one of the organ failure is of course the kidney and the occurrence of acute kidney injury. And here, in this large population of critically ill patients, not all patients with a cardiogenic shock, but probably many of them with shock, you see that an increase of 1 centimeter of Whopper of CVP was associated with an increased occurrence of acute kidney injury. So this is something really that you have to monitor to limit the kidney congestion and to improve the kidney function. And this is probably much more interesting, this study. It's not cardiogenic shock, this is advanced heart failure, decompensated advanced heart failure, just to show you that it's not the cardiac index which will predict the worsening of the renal function during the hospitalization, but it was the CVP. And this is probably much better reflected here. Here you have the glomerular filtration rate, so the kidney function, when the cardiac index was low, which is not good, but the CVP was low, which is very good. And here, it was the same situation, but with a high cardiac index and a high CVP. And you can see that the kidney function was much lower in case of high CVP despite a normal cardiac index or even high cardiac index. So definitively monitor the CVP in this situation. So if you look at the different causes of RV failure-related cardiogenic shock, that's difficult to say which ones, probably RV infection and probably pulmonary embolism. But if you enlarge a little bit the discussion to RV failure in the critically ill patient, as you know, you have many other causes, and especially related to pressure overload in our patient under positive pressure ventilation, with a true action on the pulmonary circulation due to the inflation of the alveoli. Just to focus my lecture on the cardiogenic shock and especially RV failure, and here related to RV infection, you can see that it is around 5% of all patients with shock related to acute coronary syndrome. Usually, as you know, this is the right coronary artery which is obstructed. The in-hospital mortality is high, 50%, but finally not so different and quite similar to the mortality of patients with shock related to LV failure. I show you the typical pattern of RV infection in this mechanically ventilated patient. This is TEE. You recognize the LV, the RV, the right atrium, and look at how the right heart was dilated without at least no contraction of the RV free wall. Look at the short axis view by a transgastric approach. This is the anterior wall of the LV, and this patient had actually a myocardial infection of the posterior and inferior wall. You can see a completely akinetic segment at the inferior wall. And look at a few hours or few days later, after the natural evolution and after resuscitation of patient, especially infusing norepinephrine to restore the blood pressure, you can see that the RV is still very hypokinetic at the RV free wall, but you visualize very nicely without any measurement that the psi was much lower here compared to baseline. So the hemodynamic situation of the patient really improved here compared to the admission. Other usual cause, as you know, that you have systematically look for when you have to face to a patient with a shock related to RV failure in the context of myocardial infection, which is mechanical complication and especially septal perforation at the basal part, usually of the interventricular septum. You see that this is very infrequent, as this is around 0.2 or 0.5% regarding the patient with myocardial infection. Usually it occurs very early during the following hours or days sometime, and the prognosis is very bad. Diagnosis is very easy to do. You have the myocardial infection. As I told you, you have the sign of shocks. You have congestion. If you look at the echo, you see that the RV is dilated. But now you may observe some contraction of the RV free wall. And so this patient did not have any extension of the myocardial infection to the right ventricle, but rather a perforation of the basal part of the interventricular septum. This is subcostal view, and you see here the hole at the basal part of the interventricular septum. So very quickly, in a minute, you may have the diagnosis at the bedside to propose a treatment, even though the outcome is very bad. Another usual cause, if you work in a cardiac ICU, which is the RV failure in a perioperative or immediate post-operative cardiac procedure. And I show you all the causes of RV failure that you may observe. There are many. Maybe, for instance, post-surgical myocardial dysfunction due to suboptimal myocardial protection could be a usual cause. Or, of course, other cause as a pre-existing RV dysfunction. The RV failure in this situation is quite infrequent, 0.1% after cardiotomy, but after 2 to 3% after heart transplantation, and especially 20 to 30% after LVAD, because LVAD is very well known to induce some RV failure and shock in a previously injured right ventricle. So once you did the diagnosis, I mean, this is a different steps. Once again, not only focus on the cardiogenic shock, but more generally focus on the RV failure management. So step 1, assess the severity, especially using the clinical evaluation. And so the CVP, the pulse pressure, the skin, and so on, very usual signs that we have. Step 2, identify, of course, and treat the triggering factor. So if we only focus on the cardiogenic shock, this is usually, let's say, infection with mechanical complication. But as you know, in the ICU, you may have many, many other causes of RV failure, as sepsis, ARDS, positive pressure ventilation, pulmonary embolism, and so on. Step 3, optimize the fluid status. This is really key, and I will show you 1 or 2 slides about this part. Step 4, maintain the arterial pressure, and probably that the right drug and the magic drug for the RV function is norepinephrine. I am not completely convinced about the levosimendant. I do not remember who spoke about that. This is physiologically, this has sense, because indeed, you vasodilate the pulmonary circulation and you increase the contraction of the RV, so you improve the coupling. But the problem is that we miss a lot of data. In my mind, I have only 1 study, for instance, in ARDS patient, so I think we need more before recommending levosimendant infusing in this situation. Consider inotrope infusion, for instance, the butamine. Just be careful, because if you have isolated RV failure with a preserved LV ejection fraction, LV systolic function, you can do very bad by infusing the butamine. You increase the heart rate, you increase the contractility of the LV, and at the end, probably you do not improve so much the patient. So reserve this inotropic infusion in case the RV and the LV both are failing. And of course, just always consider to increase as much as you can the RV afterload, not to add a supplementary load to the RV. Just about the fluid management, I think this is really key because first, probably in case of RV failure, if you give more fluids, this is useless. It's not a big problem, it's useless, but don't do that. I will show you just after why. Here, for instance, this is the series I show you in septic shock patients. You have the size of the right ventricle here, you have the pulse pressure variation here, and just look at here at the right upper corner of this figure. This is very red. Red means that the patients were very unlikely to respond to fluids. So despite pulse pressure variation, when the RV was dilated, you did not increase the cardiac index. We did not increase the cardiac index after giving more fluids, which was here a passive leg rising, so a reversible fluid expansion. And more, this is bad. This is deleterious for the patient. So we do not have many clinical data. We have a lot of experimental study. I'll just show you one. This is a model of obstruction of pulmonary circulation, as you may have in the pulmonary embolism. Look at here at baseline. During the obstruction of pulmonary circulation, the cardiac output decreased, the RV stroke volume decreased, the pressure into the right heart increased. After volume, you worsen the situation, more decrease in cardiac output and stroke volume, more increase in RV pressure. And finally, as I told you, this is a norepinephrine infusion in this study, which was able to restore the hemodynamic situation and to improve the situation in general. So I want to conclude now to keep my time. So the right ventricle plays a role in cardiogenic shock. There is no doubt about that, even though sometimes we forget this right ventricle. RV failure is the usual cause of cardiogenic shock. Even if not very frequent, I am completely unable to give you the exact incidence in the cardiological field. Maybe you can give me the incidence, but I don't know. Echo and CVP should be associated, for detection. This is really key, detection and monitoring to adapt the treatment. Myocardial infection with its complication is clearly probably the first cause if we only focus on cardiogenic shock. As I told you, if we enlarge to RV failure, we have much other causes of RV failure in the critical care settings. And definitively among management, feeding is useless and even contraindicated in many, many cases. Thank you for your attention.
Antoine, as always, thank you for this brilliant presentation. Thank you for staying in time perfectly. And we have now time for one or two questions from the audience. Here is one.
Maybe with the microphone, because we do not have the, we cannot hear very well on the podium. Sorry.
Do you think there is any role for the Swangans for monitoring the right heart failure?
If you look at the guidelines, the answer is yes. And this is really surprising for me always, because usually the guidelines said that there is no room for the Swan-Ganz catheter, but in case of RV function impairment, you have to insert a Swan-Ganz catheter to monitor the hemodynamics. This is something very surprising for me, because I will say that if there is one situation where the echo is very easy to perform, to detect easily and to monitor the RV function, this is when there is some RV failure. So I was interested by the recent study reporting, not really a study, a registry reporting that probably we may improve the prognosis in cardiogenic shock by inserting the pulmonary artery catheter. So I don't want to go too much into this debate, but I remember now all study, all trials that did not show any signal regarding this hemodynamic monitoring. So I can just tell you that I don't use it for managing RV function impairment, but you can do, of course, as you want.
Thank you.
There's another question.
Thanks, Antoine, for the nice presentation. I want to ask about the role of a new index of right ventricle, the PAPI, the difference between the systolic to right.
You mean the difference? Ah, okay. Okay. So the transpulmonary gradient.
It's a very good marker in
Yeah.
order to decide also for
Yeah.
mechanical support of right ventricle.
So just to be sure to be sure to understand the question, you speak about the transpulmonary gradient, for instance, which is the difference usually between the mean pulmonary artery pressure and the PAOP, or in the very old story, the diastolic pulmonary artery pressure and the PAOP. That's right? I think it's a very good parameter, and personally, if I will insert a Swan-Ganz catheter, this is one parameter that I will look for, because it gives you many information, not really about the RV function, but about the status of the pulmonary circulation. But you may consider that in case you have an enlarged difference between these two pressures, probably that the RV is not in a good shape. You have some precapillary afterload. Finally, this is no more than a precapillary pulmonary hypertension sign.
So you are in favor of Swan-Ganz?
Yes.
Antoine, thank you very much.
Okay,
Again.
thank you.
And in the interest of time, we'll go on to the next speaker, Professor Matthias Herringlager from Germany, who will tell us that there is still a place for the intra-aortic balloon pump in cardiogenic shock.
And thank you very much for the kind introduction, Marcel, dear colleagues. This is probably a rather interesting debate we are going to about the use of mechanical support in this situation, and it will also a little bit deal with a recent guideline that has changed. Well, within the next 50 minutes, I will try to give you a short overview about the current role of the intra-aortic balloon pump. This has already been said more or less by the first speaker, but it will present several arguments why this device may be useful in the patient with a cardiogenic shock as well in the cardiac surgical field, and we'll try to highlight that the results of the other devices of mechanical support are tremendously disappointing, and go a little bit onto the recent guideline recommendations, but not only for the cardiogenic shock, but also for the cardiac surgical field. Well, this is another registered data paper recently published showing that the use of the intra-aortic balloon pump has tremendously decreased since 2012, the year the Shock 2 trial was published. And you all know this study, so it's probably not necessary to go in the details of the results. This is something you know, and you also know that the guidelines have changed. This is the 2012 guidelines, where the intra-aortic balloon pump still had its place as a mechanical circulatory support system, and that was abandoned some years later following Holger Thiel's trial. Well, this is at least a little bit astonishing, because we are dealing with a device that's on the market since more or less 15 years. It has been used extensively in various settings, and all people that worked with this device were highly convinced it works. It improves cardiac output, not in all patients, but in some, improves organ perfusion, and thereby will most likely improve the outcomes of my patients. If you go for a little bit more sophisticated technology, it's not astonishing that this device works. It reduces afterload and leads to an increase in stroke volume. A patient with an ejection fraction of 14%. Not in a cardiogenic shock situation, of course, in a more or less stable situation. But this device helps the heart to eject more of its volume. And colleagues from Columbia University looked for their own data, and they looked specifically on patients with acute decompensated heart failure and cardiogenic shock, and those with acute myocardial infarction. And in a relevant number of patients, there was an increase in cardiac output. There were some super responders, up to 3-liter increase in cardiac output. And there was, of course, a little bit different pattern in the patients with acute myocardial infarction. In these, only 50% of the patients showed an increase in cardiac output, but this can be easily explained by the inflammatory state we know is a hallmark of the myocardial infarction situation. And the lower the vascular resistance, the lower is the efficiency of the intra-aortic balloon pump. Well, some more recent data point that it's probably not a bad idea to use this device. Retrospective case series, again from Columbia University, with a mortality of 16% in patients presenting with cardiogenic shock, but treated with an intra-aortic balloon pump and then further treated with necessary devices brought to an elevate or to heart transplantation. Actually, a situation in the acute decompensated heart failure situation where the intra-aortic balloon pump worked. But also in a more broader setting, these are not from, I think they are from Yale, these data, heterogeneous cardiogenic shock register, they had a higher mortality, but what they observed, and this is again in line with the first presentation, the earlier you insert the device, the better is the outcome of your patient. The mortality rate of 20% of the device was inserted 20 minutes within 1 hour, and a poorer survival, of course, if it was inserted later on. And it's probably not only the cardiogenic shock situation due to myocardial infarction and also acute decompensated heart failure. This is a study in which more than 900 patients were included, and one-third, roughly, were treated with an intra-aortic balloon pump. You can see here the mortality in all settings, and even in all different types of shock states, were tremendously improved by simply using this old-fashioned device. As a cardiac anesthetist, I'm, of course, rather familiar with the use of the intra-aortic balloon pump in the field of cardiac surgery. Interestingly, I think it was 2 years ago, when we looked for someone speaking at an autumn meeting in Fulda on the topic of intra-aortic balloon pump and their own experience, I didn't find a speaker, because in most cardiac surgical centers, this device was no longer used. It was somewhere in the cellar, or simply, even people were no longer accustomed to it. Astonishing, this, because we have relatively convincing meta-analysis showing that in observational and randomized controlled trials, a preemptive use of this device in a high-risk patient is capable of reducing its mortality and morbidity. And this is also true if you look for the sparse randomized controlled trials, even including after one negative study from Brazil. We end up with a message: this device in the high-risk patient used preemptively reduces mortality. But one important aspect is you shouldn't switch it off when you're on pump, because this is a British study, but there are also some larger Japanese data on this. If you use the intra-aortic balloon pump perioperatively and when the patient is on cardiopulmonary bypass, the pulsatility induced by this is extremely helpful for organ perfusion. You can use the incidence of acute kidney injury as well as malperfusion in the visceral area. Well, some of you will find this astonishing, but I try to bring you through some statistical criticisms on this SHOCK 2 trial that has changed the guideline. If you go for the methods, you will find that the study was powered to detect a 12% absolute difference in 30-day mortality, assuming a 56% mortality in the control group. This was actually the control group of Judith Hochmann's SHOCK trial, published in 2006, looking for patients treated in the last century, and actually not the mortality that was observed in the pilot IRBP SHOCK 1 trial, performed 30 or 40 kilometers apart from Leipzig in Halle, where the colleagues observed that the mortality was between 32 and 24 of note higher in the intra-aortic balloon pump. But if you use these numbers and calculate a relative reduction in mortality, you will see that the numbers you need to show this difference is much higher. And what we all know, and we have all seen in this paper, are always the intention to treat analyses. Interestingly, more than 10% of the patients in the control group were also treated with an intra-aortic balloon pump. And if you look specifically for the results in the patients not treated with an intra-aortic balloon pump and those treated with an intra-aortic balloon pump before revascularization, the optimal time point before the heart was revascularized. You see this is an effective mortality difference of 5%. And if you put this into your statistical program, you will end up with a significant mortality benefit in patients treated with the intra-aortic balloon pump. Completely different to what we know and completely different to what has been the basis for the guidelines, but probably worth to think about if we are not treating patients that have been treated with an intra-aortic balloon pump almost 15 years ago, for more than 15 years. Well, the first talk was a little bit enthusiastic about the use of other mechanical support systems. But if we go for some recent data, as looking here, for example, the Impella device, higher mortality, higher bleeding rate, higher acute kidney injury rate. And if we look for some registered data from Germany, you can see here, these are patients treated with an ECMO, at best 30% survival, and these are the patients treated with intra-aortic balloon pumps because there are still some centers that are adhering to this technology. Probably the best thing you can do for your patient. And if we go for the cardiac surgical field, we don't have any randomized controlled trial. What we have are registered data showing that it's almost impossible for a patient to survive if he's treated with a mechanical support like ECMO or ECLS. And it's those that survive, at least my personal opinion, are those that have never needed any kind of mechanical support at all. But one specific situation brings both technologies clearly together. If we look for the problem that the classical ECMO ECLS system faces a tremendous increase in afterload for the failing left heart and thereby can never be a really good option to rescue, save the heart, the use of an intra-aortic balloon pump in this situation helps the patient to survive. It's better than the Impella because this is significantly different and has a much higher complication rate. And both things are even better than the use of the ECMO alone because this is clearly an option to stress the heart, but not to help him to survive. And to go back just a second, here you can see that this was also true following multivariate analysis, and the pre-ECMO ERBP was beneficial. And by this, it's more or less reasonable to start with the intra-aortic balloon pump, and if it doesn't work sufficiently, to add on the ECLS system. This may be helpful, and I wonder if Alan Combe will bring some additional information on this topic too. Well, what about the recent guidelines? One, of course, it's only an expert consensus document on the use of the intra-aortic balloon pump. High grade of recommendation to use it in the high-risk patient with acute heart failure in a situation that is undergoing cardiac surgery. And the poorer option is to wait for mechanical support. And if we go for the ESC guidelines, it's probably worth to look for the short definition of temporary mechanical support that is brought up here in these flow charts. It includes the intra-aortic balloon pump. And by this, it has got an upgrade to an 2A recommendation. I'm fully convinced that it's good. It's also still useful for the patients on which we do not know how we shall proceed with them in the future if we probably try to bring them on an LVAD or so. And this is something we probably have to discuss if it's really the optimal way to treat our patients. And thereby, I'd like to conclude that the intra-aortic balloon pump does indeed improve hemodynamics and organ perfusion in many patients. In acute decompensated heart failure, probably even in the majority, as shown in this Columbia University paper. The increase in cardiac output is more pronounced if the vascular tone is high, so don't wait until the patient is inflammatory, vasodilated. Then the system will probably not work that perfectly. And it's helpful to improve outcomes, especially in the cardiac surgical field if it's used preemptively and prophylactically. And especially if it's not switched off during CPB. Think about if one trial should change practices from that have been used for decades, and there are probably not so many really good alternatives because the mortality of the current mechanical support systems are tremendously high, and they have never been proven in randomized controlled trials. And even if you have an intra-aortic balloon pump in place, it doesn't work, and you have a patient in which you think it might be useful to expand your treatment further, then you can think about implanting an ECLS on top, and the intra-aortic balloon pump will help to unload the left ventricle in this situation. And thereby, I thank you for your attention and hope for one or two questions.
Excellent. Thank you very much, Professor Herringlaker. Your lectures are always a breath of fresh air, and I truly appreciate the protocol analysis of the Shock 2 trial, which was again an eye-opener for me. And I think your lecture complemented Professor Parisi's lecture very, very well. So thank you for those clinical tips of how to select patients for IABP. Questions from the audience?
Thank you very much. As I always tell my colleagues, intra-aortic balloon pump is like a football league game. When there is a need, you have to come the believers in and the non-believers out.
Yeah.
Yeah, and I am definitely a believer, so maybe you didn't understand. I said that I completely complain with the guidelines because they say the intra-aortic balloon pump is not useful in shock, but is useful in shock with mechanical complication.
That makes sense, of course.
If something someone can explain to me, but okay. But what I want to say is that also intra-aortic balloon pump, and I always use that. I'm really a believer, but sometimes you have to be really careful, and in time, you have to implant something more aggressive. Because, again, if you implant ECMO, in the majority of the cases, as it's done now, I mean, it's like calling the priest. So ECMO or priest sometimes is the same thing. So don't do that. So do it in time. This is very important, not when the lactates are 20 and then you want a miracle. So intra-aortic balloon pump, it was very badly judged in the past. I think it's still a very useful, but again, as intra-aortic balloon pump and the other mechanical circuit support should be used in the right time, in the right patients.
Yeah, I completely agree. And I think we have one thing in common. This was also one of your slides. We use technology to estimate the hemodynamic status of a patient. We use a PAC. And the problem of, for example, the Shock 2 trial is we don't know what these patients had with circulatory state they had. Yeah. And so in the cardiac surgical field, it's really simple. You check the numbers, you see the numbers don't increase in a way like you like, and you know that it's good for the health of your patient, and you can escalate, but that is reasonable. Otherwise, to put it in everyone, that doesn't make sense.
Definitely. I book you for a lecture in my center or a beer later together, but I want to say one thing. If you look at the study design of Shock 2, you will see that in the intra-aortic balloon pump, there were significantly less patients undergoing more advanced mechanical circuit support. So the intra-aortic balloon pump was even able to reduce the need of major, more advanced treatment. So definitely it was, I think, well, I'm no one, but the study design was certainly not very fine. Thank you.
Thank you.
Well, thank you very much for that very good lecture and a nice discussion as well. Professor Alain Koum, I would like to say a very warm welcome to you, and we look forward to your lecture on VA ECMO.
Thank you so much, and once again, it's such a pleasure to be here today in Brussels facing you guys. It's been so long. Well, what might be the indications of VA ECMO for patients who have cardiogenic shock? Which population of patients? When should we decide? First, a very brief introduction about the indications. Most of the indications are actually patients who have medical cardiogenic shock, and it's acute MI, which is the most frequent reason for initiating ECMO, but it might be also patients with end-stage dilated cardiomyopathy, myocarditis. Septic shock is increasingly recognized also as a significant indication. All these patients should be refractory to conventional treatments, including inotropes. We might discuss the balloon pump at the end of this talk. It's also very important to recognize these patients early on, because once they have developed end-stage multiple organ dysfunction, then the prognosis is much poorer. Second population of patients, those of you working in cardiac surgery departments, post-cardiotomy, specific populations of heart transplant patients, VAD patients. There's many specific indication there. It might be a little bit different from the medical population. And I would say just a few words also of cardiac arrest, what's been called eCPR, ECMO for CPR. So we probably also should discuss now, in light of these so-called new classification of cardiogenic shock, the SCAI stages from A to E. A and B are mainly patients with pre-shock, C being the classical definition of shock, and D and E being the most severe forms, with E patients being those who fail on classical treatment, and those who actually receive ECMO and what may be the so-called accepted indications when looking through the literature, especially for MI patients. It's mostly patients with this stage E SCAI classification who are receiving the technique, and this is what we reported a couple of years ago now in intensive care medicine with this Anchorage series of patients with 138 patients. The ICU survival rate was close to 50. 15 years ago was less than 20. So maybe with a better selection of the population of patients, we did better. And the other good news is that for those who survive, most of them, 2/3 of them, was successfully weaned from the machine with no need for VAD surgery or transplant surgery. So there's a potential for recovery in most of these MI patients. And also, the 50% of the patients who died mainly were those who had severe organ dysfunction at the time of ECMO initiation. Other population, as mentioned before, dilated cardiomyopathy. It's also possible to bridge patients to either directly to a heart transplant. We do that regularly in our department. Although now there is a new allocation system in France in which it's only a 15 days time window after ECMO initiation to transplant a patient. Might be a little bit too short for these, at least for the MI patients, but might be possible for those who have dilated cardiomyopathy, or you may use ECMO as a bridge to bridge once you have stabilized the patient to bridge the patient to a VAD or to a total artificial heart. Also, we can insert here in our department. Fulminant myocarditis may be the best indication in terms of results. These are all data from our center, but still a lot of data from the literature now suggesting that the survival rate may be close to 70, maybe even higher in those patients with myocarditis. We also have seen an increase in the number of COVID-19 patients developing severe myocarditis, especially with the latest variants, especially the Alpha, and maybe even more with the Delta variant, with a quite good recovery of heart dysfunctions. Cardiac surgery, also very specific. These are data from a huge database of heart surgery patients, showing first that the indication altogether is less than 1%, with results maybe being a little bit better over years, but still a mortality rate which is in that database over 60%. Heart transplant. It has completely changed the way we manage patients. Those are data from our center in La Pitié-Salpêtrière, where we're doing close to 100 transplants per year, but similar data coming also very recently from the US after they modified the UNOS criteria. And as you can see here, it's only for those patients who need ECMO post-heart transplant that the survival rate is lower. Those patients were bridged on ECMO to heart transplantation at a similar outcome than those who got a heart transplant without being on support before the transplantation. So these may be what may be called the classical indications, and we're looking in the coming years, there might be emerging indication first for those patients who have catastrophic pulmonary embolism, little emboli like those on the slide. This is something we reported on a small series of patients a couple of years ago. And the potential use of ECMO might be for sure to rescue those patients who had cardiac arrest and who recovered. It might also be possible in patients with refractory cardiac arrest, although you may need to get ECMO within a couple minutes following arrest if you want to have a decent prognosis. And once the ECMO has been set up, there might be a discussion between just wait with heparin, go to the cath lab to have a catheter-based embolectomy, or ask the surgeon to remove the clots. The solution to that question is not settled yet. A few words of ECPR. It's this ECMO for refractory cardiac arrest. This is actually feasible if you select the right population of patients. This is the experience of this Yiannopoulos from the University of Minnesota, focusing on patients who have refractory out-of-hospital cardiac arrest with VTVF, shockable rhythm, and who are rushed, load and go, to the closest hospital, to the cath lab, where ECMO is set up, and the artery is reopened, and after ECMO has been set up. And the mortality dropped from 85 to 55%. And Dimitris has published this very nice paper in the Lancet. It's one model of an RCT which might be conducted in a very complicated population of patients, showing that the survival rate with good neurological outcome is 0 in patients who have conventional treatment, and was close to 50 for those who got ECPR. So it's a changing study in the way those patients might be treated in the future. Still, be careful, because it's a very highly selected group of patients, and those are data from the Paris sudden deaths registry, showing that uncontrolled use of ECMO for out-of-hospital cardiac arrest leads to a very high mortality and no benefit at all after controlling for coviable propensity score matching, multivariable analysis. There was no benefit of the strategy. So, well, wait a minute, think about it. You might go to the Père Lachaise cemetery in Paris and put ECMO in dead patients. This will not work for sure. And we need to define the population of interest for this very difficult activity. Those patients should be probably less than 50 with on-site witnessed cardiac arrest with a virtually zero no-flow, bystander CPR, initial shockable rhythm, and a collapse to ECMO time, the time from collapse to the time the machine is running, which should be less than 45 minutes, for sure less than 1 hour. Septic shock also might be an indication in the coming years. These are data from an international case control study we conducted a couple months ago, and which showed that also for a very selective group of patients, those who develop severe cardiogenic shock with LV dysfunctions, low cardiac output in the setting of septic shock, might strongly benefit from ECMO. We match cases and controls. Controls were those who had been included in large RCTs of septic shock in France. So it's very careful matching a high number of variables here, and showing that the survival rate was close to 60% in these patients, was less than 20 in those who did not get ECMO. So it might be in selected patients also in a good opportunity for saving lives. Last but not least, cardiac myocardial infarction, and looking in the close future, for expanding the indications, not just those patients in class E, but maybe going for ECMO early on in the course of the disease. Patients with class C, D, and E might benefit from this strategy. And actually, when looking at the culprit, which is one of the biggest trial on cardiogenic shock published so far, this is not in the main paper, this is in the online supplement, and looking at the reason for death, this was not from brain death or the cause of disease. It was mainly from refractory cardiogenic shock. More than 2/3 of the patients died of refractory cardiogenic shock. Those patients might have been salvaged should ECMO have been initiated early on. And this was underlined by Judith Hockman in this editorial in the New England, suggesting that we now need data from RCTs of ECLS ECMO, VA ECMO in these patients. There are 3 studies currently ongoing, and this is the one we are doing in France, the ANCHOR trial, which is now recruiting patients, and with the hypothesis to decrease mortality in these patients. In the ANCHOR trial, one of the specific aspects is that we're combining systematically the balloon pump on top of ECMO to decrease DLV and diastolic pressure, because we strongly believe this has an impact on the outcome of the patients. So this is my last slide, tribute to my team in La Pitié-Salpêtrière, who did such a hard job at hard times in the last 18 months. Thank you so much, and once again, if some of you want this paper, I may send it to you. Thank you so much.
Thank you very much for this crystal clear presentation and summary. I guess we only have time for one short question and answer because we need to clear the room for the next session. Any question from the audience? Then I will have just one short one. The criteria you mentioned for ECMO after cardiac arrest, are those the criteria you use in clinical practice, or is it something that you would suggest to evaluate in future studies? So what do you do right now?
Yeah, we most of the time deny the indication for ECMO for those patients who have non-shockable rhythm, prolonged no flow time, of course. Also prolonged low flow time. Is the protected low flow time is over 1 hour. It's clearly not reasonable. But then you may have emotional indications. Very young patients. We did 2 months ago, 14 years old. And he did survive. And he did receive his CPR after more than 1 hour of CPR. Same for PE in a pregnant woman, which is always some kind of emotional issues. But for most indications, yeah, you need to stick with these indications, because otherwise the mortality rate you get is over 95%, and it's useless, and it's a lot of resources and also a very deep impact on your team.
Right, okay, I think we'll close now. I'd like to take this opportunity to thank each and every one of our speakers for those excellent lectures, and to thank you all for coming. Have a good Congress.